Hello everybody and welcome to our first Ask the Expert Q&A, where you can get to ask questions and critically get answers from experts about important PSC issues. My name's Martine Walmsley and I'm the Chair of Trustees and volunteer for PSC Support, and I'm a PSC patient, and I'm here with Maxine Tapp, PSC Support Programme Development Officer. And we're delighted to be joined here today by Dr Andrew Yeoman. And Dr Yeoman is a consultant hepatologist at the Gwent Liver Unit and is a clinical lead for the Wales Liver Disease Delivery Plan. And he's a member of the Lancet Commission into Liver Disease, and he served on the BSG guidelines development groups for abnormal liver blood tests and autoimmune hepatitis. And he's also a steering committee member of the Basel Immune-Mediated Liver Disease Special Interest Group, and last but not least, a PSC Support Expert Panel member. So we couldn't be in better hands here today as we think about our own healthcare and how it's been affected by COVID-19. And also the Gwent area has been a hotspot for COVID-19. So Dr Yeoman knows very well the impact that this has had. For those watching live, you can add your questions in the comments below this video, and we have been inundated with questions sent in advance, so we'll try and get through as many as we can in the next 30 minutes. So welcome, Andrew.
Martine, Maxine, thank you very much for inviting me to speak to you all this evening. And I thought it'd be quite useful to sort of set the scene by talking a little bit about what's been happening within healthcare systems, particularly through the lens of what's been happening in Gwent, my own area, but what's been happening in Gwent will have been replicated across the whole country. So I thought it might give the membership a bit of an idea of what was happening within healthcare systems, particularly hospitals. So what we've got here is a graph of COVID positive recorded cases. So that's swab positive tests within my health board area. And our first case was actually around the 13th, 14th of March. But we knew this was coming quite some time before that. We knew this would be a significant health issue, probably at the beginning, end of February, beginning of March. We knew it would be big. We knew it would have a huge impact on our healthcare capacity, and we knew it had the potential to infect and make seriously ill a large number of people. So we had what's called this preparation phase from really about the 8th of March up until about the 17th, 18th of March. And we had our first admission to hospital on the 17th of March. Now, as you might remember, lockdown didn't happen for another 6 days after that. And then we were very much in what I call the high acuity phase. That's where the hospital system massively flexed. So in that preparation phase, we focused on increasing ITU capacity. There was mass redeployment of clinical staff. So hepatologists went back to do general internal medicine. Whole rotas were ripped up. Annual leave was cancelled. Everybody sat down and thought, how can we design a system that will be provide safe and effective care for what we anticipated to be an enormous surge in a number of people admitted to hospital with COVID-19. You can see then through that high acuity phase that the bar which identifies the predicted start of the lockdown effect, we start to see a reduction in the number of positive cases more or less day by day. There are peaks and troughs for the weekend effect in terms of when the tests are actually tested rather than sent. But you can see there's an overall gradual decline from about 10 days on after lockdown. And that's important because we know that from exposure to symptoms is around 10 to 14 days. And from about exposure to hospital admission is around 15 to 20 days. So that's really start to see a reduction in the number of positive cases if lockdown's having an effect. And we think it did have an effect. We can't prove beyond all doubt, but we think it did have an effect. And so really that took us up to really the end of the second week of April. And then we entered into a bit of an uncertain phase. Was there going to be a long drawn out tail of COVID infection and sustained high number of admissions? Because in that high acuity phase, our ITU had 3 times the number of patients that we would normally have on it. And there were 150 patients in the hospital that had coronavirus infection, which is quite a large number. But actually we saw continued reduction in that, and we've now moved into what's called a restoration phase. So all that activity, so that's the cessation of hospital clinics, of face-to-face clinics, of endoscopy services being massively restricted in terms of their capacity. Those things are now in this restoration phase, which began for us really in the third week of April and continues on. And week by week, we're increasing our endoscopy capacity. We've started to do bowel screening again. We're starting to do routine or urgent colonoscopy lists again, and started to try and claw back the backlog of work that we had to defer to get ourselves ready for that huge surge in capacity from COVID. So that was really just to give you a flavour of what's been happening within healthcare systems. This is by no means unique to Gwent. Every single hospital trust in the UK will have been adopting a similar process. And the important thing is that both in the preparation phase and in the high acuity and now in the restoration phase, there's been a sea change in terms of the way we try to identify and get patients flowing through systems. So most hospitals will have separate areas for people who have COVID suspected infection, not just definite infection, but if you've got symptoms that are suggestive, people are looked after in different clinical areas and isolated as much as possible. And we saw in the preparation phase, in the early acuity phase, we saw probably a reasonable amount of hospital transmission, but we're seeing very, very little of that now, because the processes that we put in place, the PPE that's been in place now for a couple of months, is really having a really positive impact in terms of preventing people when they're admitted for other reasons from acquiring coronavirus. So it's really just to try and give the PSC community a bit of a flavour of what we as healthcare professionals have been doing. That may answer some questions, but I think it might be a good time to go on to answer some of the specific queries that have been raised so far.
Thank you, Andrew. So as I said, we did get lots and lots of questions, and it might help if we split them up into categories. So we had quite a lot about going into hospital and what's going to happen in hospital. So the first question we've got here is it better to have a blood test at home or in the GP or hospital?
That's a really good question. I think it comes down to what arrangement has been put in place in your local hospital. And I think some hospitals are not doing outpatients and phlebotomy in the main outpatients area, but they're doing them in community hospitals or in GP surgeries. And I think the bottom line is that what we have to try and do is try to minimize the risk. There's no situation where we can completely eliminate all risk of people catching coronavirus. But the things that will mitigate the risk or minimize the risk are having minimal exposure. So that's having less contact with people who are highly infectious. And that's the purpose of trying to run things in outside of major acute areas. So that's making certain that, if you've got a waiting area, that it's all appropriately socially distanced, and that there aren't people with acute respiratory illnesses coming into that waiting area. And hospitals will have done that with their phlebotomy services. You have to remember as well, on the flip side, that a community blood test done by a district nurse is not completely foolproof either, because that person will have gone through many other homes and may potentially have picked up coronavirus. Now, obviously, the district nurses are adhering to very high standards of hygiene and with very high standards of PPE. So I think the bottom line is whatever your organisation and your healthcare system where you live is offering you should be safe for you to go and have your blood test. And I think we need to just understand that this isn't about eliminating risk completely, because that's almost impossible. It's about how do we reduce the risk to the absolute minimal. And that's where things like using masks when you go into clinical areas comes into it. We certainly do that for our outpatients areas now. Anybody waiting for a blood test in our community hospitals or our main hospital sites are offered a mask to wear. There's extreme social distancing in the waiting area, so there's not people sat next to one another. There's actually much greater than 2 meter separation of people in those waiting areas, and people are sat next to one another for very limited periods of time. So for phlebotomy blood tests, the risk is extremely low. And this is about trying to identify what system has been put in place in your hospital. And if you don't know, you can ask your hospital consultant, the team, where the phlebotomy service is currently being held. Because some GP surgeries haven't been able to offer that service through this period. Some haven't maintained that service. So it's about trying to understand the care navigation in your own locality, which I know is challenging, but understanding that we need to try and find systems that enable us to live with coronavirus rather than completely abolishing the risk. But being in socially distanced environments, being there for limited periods of time, and using face masks and very importantly as well, fastidious hand washing after any contact, then we can make that risk so minimal as to not be a barrier to people having their blood tests.
Thank you. And it's really reassuring to know that hospitals are taking steps to try to minimise that risk. And I think it is a concern for patients, because patients don't know what it's going to be like in the hospital. So it's good to know they could just phone up and just double check what that system is in their hospital.
Yes, I think it's important. As I say, it's very difficult to give a one-size-fits-all answer to that. So I think it's about empowering the patient to ask the right questions, so they can be reassured that the environment they got into is safe.
So that actually brings us very nicely onto another question we've had, which is about people who've got routine appointments scheduled. They're still getting their letters saying, yeah, your appointment's Tuesday. What would you say to someone that's got a letter like that is wondering whether, do I need to go? Do I not need to go? What's the situation?
My first response to that would be to ring the secretary of the consultant involved, and the number's usually on the letter. If not, there is a number you could be able to contact in the bookings department to ask the question. Because whilst I think people often feel that every single hospital appointment is directed by the consultant, the sheer number of people that we see in our follow-up clinics and new patient clinics is such that the bookings departments take those things on, and sometimes clinic appointments are generated sometimes somewhat randomly. And whilst that doesn't sound ideal, if you think about an organisation the size of mine, we have several million outpatient activities every single year across primary and secondary care. So to try and get a system that is sophisticated for every single event within that is very, very difficult. So sometimes it's perfectly acceptable for a routine appointment if you're well and it's a routine follow-up appointment. Sometimes those can actually be deferred. And if you're particularly anxious about going out and you're in the shielding category, then that might be the appropriate thing to do. But your healthcare professional is going to need to know that that's safe for you to do, so they're going to need to have involvement in that decision. And so the first protocol would be to contact the secretary and ask is it absolutely necessary for me to come to this appointment? Is there anything else I need to have done? Do I need to have blood tests? Do I need to have any other sort of form of monitoring? Can I have a telephone clinic? Or do I truly need to be seen face to face? So it's about empowering people to ask the questions and don't be afraid. That's what the secretaries, they expect those questions to come from people. We fielded huge numbers of those queries. So we expect those queries. And so don't be afraid to ask those questions.
Thank you. No, that's really good to know. And the next question is slightly related to that, and it's around having telephone appointments and how all these other tests fit in. So this person has had a course of antibiotics because they've had a low-level infection that was diagnosed by the GP, and they've had blood tests and they've had an email from the liver team. They're due a telephone appointment and they just want to know what will happen about the follow-on blood tests and if they need to ask any specific questions.
Yeah, so I think whenever you have a blood test taken, it's really important you understand why it's being taken. Is it a routine thing that we just check as part of your ongoing clinical review, or has it been requested for a specific complication such as cholangitis, for example? And then you need to understand what the result is and what that means in terms of next steps. So I think these coronavirus issues are very pertinent to actually improving self-care, longer term, and actually making sure the patient's at the heart of their care. So I think those are the three questions I think are really important. Why is the blood test being done? What is the result, and what's the aftercare plan? And so ask those three questions, because it might be that particularly if you travel far, some people with PSC have to travel a long way for their clinic visits. It's a rare disease. There's relatively little expertise across the UK in this disease area. And so, do you really want to be traveling 120 miles, just to have another blood test when it could possibly be done locally? So this is an opportunity to redesign care systems so that we can perhaps try and have better systems that people can have their blood tests done. Historically, I think we've done that because we know if somebody comes to a central clinic, you've sent that person to that blood test and the result will be available the following day. So there's a bit more flexibility required from us as doctors in managing that, knowing that blood test result may not be there for a couple of days. But again, don't be afraid if you've had a blood test done, if you've been looked after in Birmingham or some other sort of very specialist tertiary centre, to let the team know that you've had your blood test done locally, if that's what's been arranged, so you can help grease the wheels of that communication, which can be difficult across different healthcare boundaries. So ask those 3 questions and don't be afraid to follow up and say, I've had my blood tests, I've not heard anything back, what do I need to do next? That's a perfectly reasonable question.
Yeah, and it's a pragmatic attitude, and hopefully if anything good comes out of COVID, that could be one of them, and we'll all pay less car park charges too, which I'm sure we'll appreciate.
Yeah, there's none of those in Wales.
Oh, okay. And just talking about test results, some of them are taking a little bit longer to come back at the moment. Is it okay to phone up and ask, push along the test result? Because we've got one person they're quite newly diagnosed and they're waiting on a test and they're obviously concerned.
Yeah, of course. Yeah, absolutely. Look, I think if you're worried, I mean, sometimes as a hospital specialist, sometimes you think that I'm doing this blood test and I'm not particularly worried, but we may not have, we think we do, but we may not have conveyed that very well to you. And so sometimes we're not particularly worried about the blood test. And so, it's in the routine pile to deal with amongst everything else, which is, of course, it's the most important thing for you, but we might not be that concerned about the blood test result. And so if people have been redeployed to other clinical areas, that's another reason why there might be delays, because some staff have been redeployed. We were partially redeployed, but we're now back to doing our normal, hepatology job. So that's another potential reason, but don't be afraid to ask, because the secretarial staff is still there. There's still people there taking the calls. And most of those staff, even the ones that did get asked to work from home to begin with, and are now almost exclusively working in the main hospital sites, will be there to field the calls and the queries, because blood tests shouldn't take that much longer. Even if you're sending off a blood test, if it takes 2 weeks to come back, it shouldn't still take 3 or 4 weeks. There might be a couple of days delay. So the delay is probably more. It's always best to contact.
Thank you. And then talking about delays, inevitably, some of our tests and procedures and surveillance procedures are going to be delayed. What would you say to someone with PSC that's a little bit worried about that?
Yeah, that's a really difficult one, isn't it? Because, I mean, the first thing is obviously the surveillance for bowel cancer is probably is a more evidence-based surveillance program. The sort of biliary cancer surveillance is a little bit harder to prove that it makes an overall difference, although we believe as a liver community that it is important to do that. We wouldn't want those things to be delayed for too long, but we do know that the absolute risk within a 3 or 6 month period of people developing either colorectal cancer or biliary tract cancer is actually very small. So we know that people with PSC are at higher risk of having bowel cancer. That risk is probably 3 to 4 times the general population. But at the same time, within any given 3, 6, 9 month window, the absolute probability of developing it is still very small. So that's not to say it will never happen, but the absolute risk is small. And the risk is even smaller for biliary tract cancers. So I think whilst we don't think it's not something we don't want to abandon surveillance. We're not saying it's unimportant, but in a short period of time, the absolute risk is low. A bit like us learning to live with coronavirus, the risk is never going to be zero, but we're trying to keep that risk as low as we possibly can, and the risk is very low.
Thank you. Maxine, have you seen any going to hospital type questions on Facebook?
Yeah, so we've had one question come in. Are we expected to resume face-to-face appointments and maintenance from September, October time? So basically, I think in a nutshell, are we going to be going back to normal in terms of appointments in the autumn? Yeah,
that's a really good question. I'd like to think so. My personal experience of telephone clinics is that I've had conversations with Martine about this, is that I think they are complementary for some people, particularly if you're traveling long distances and you've got very well controlled and sometimes relatively mild disease. I don't see them replacing face-to-face clinical activity for complex liver disease care like PSC and other autoimmune diseases. The question of will September be the right time to restart is going to be predicated on really what the devolved administrations and the Westminster government say is acceptable. Because if we're still in some degree of restricted activity and still socially distancing, it's very difficult to run the size of clinics that we would traditionally do. You go to any clinic waiting room, it's usually pretty busy. There's no way you could socially distance that number of people. So then, therefore, you have to find creative ways of trying to provide care for the same number of people, but via different avenues, and telephone clinics or video Skype clinics may come into that. So I think we'll see, as I say, the restoration phase is an ongoing thing. And I think we will see increasing moves. So locally, we started off, we never stopped seeing people face to face. We always kept at least one clinic for that. First couple of weeks, there's 1-2 people there. Now we're running a minimum of 8 in those clinics because we can run those safely. And that's about, just over half of what we'd normally run in a clinic. So as we can, get to the point of once coronavirus cases drop significantly or even further in the general population, and we're not seeing a rebound when we relax lockdown rules, then hopefully we'll be able to have more people in the clinic spaces. But I think we will need to use telemedicine as an adjunct to try and bridge that gap. But it has to be for the right person. It's not right for everybody.
Yeah, brilliant. And just following on from that question along the same lines, really, there's a question here about contingency planning. Should we expect a sort of local second wave? So there's been talks about maybe having lockdown in separate areas of the country. So if that were to happen, is there any sort of contingency planning around appointments or procedures? Yeah,
well, what's interesting is that, whilst what we do in healthcare is largely driven by government to begin with in terms of principles, if you look at what happened with the surge ITU capacity, those things happened at a local level, almost exclusively. Government had no direct control in Wales, Scotland, or England or Northern Ireland. So what happened is the local team just said, we've got a problem here, what can we do? And the whole management structure in the NHS flexed to support that. And it was brilliant. We made more changes in a week, 10 days than we'd done in probably 20 years before in terms of just saying, this is how we think we need to design care. Now, obviously, the priority was huge. There was a huge need to do that. But if we can maintain some of that flexibility, that ability to just think about, are we providing the right care systems and keep that going, then that should provide better, more streamlined care. So if people would prefer to have telephone clinics, we're in a better place than we were 3 or 4 months ago to be able to facilitate that. People are much more open to that. They're using the technology now almost routinely. And people who would never have thought of bringing somebody up to do a virtual clinic or a telephone clinic are now doing it almost as a matter of rote. So contingency planning will continue to happen. And I think every locality will have its own plans for how it's worked. So in Gwent, we had to go first in Wales because we had the biggest hit, but then other health boards had to do the same. We're now moving more back towards restoring our activity, whereas some other health boards are not, because they haven't quite got over their uncertain phase in terms of cases and workload in the hospitals. So I think, yes, contingency plans will continue to be a really important thing, and they will continue to happen locally because they've always happened locally. And so local hospitals and trusts will have their own plans to do that locally if we have second or third surges.
Brilliant, thank you. So it's those little nuggets of positivity that you hear about as well, like you say, about just adapting so quickly and moving things on so quickly. It's those little things that we need to cling on to and remember during all of this chaos.
Absolutely. I think, if we can pick up, if we can keep the best parts of our COVID responsiveness plans within hospitals, I think we'll be in a much better position. It's not going to be a cure for all ills within healthcare systems, but it'll move us forward massively, I'm sure.
Yeah.
Okay, so time's ticking on, and we've still got loads of questions.
Okay.
Let's talk about COVID now and shielding. The first question here is, do you see a way out of shielding for post-transplant? And I guess we could say all extremely vulnerable patients, other than waiting for a vaccine or treatment? The million-dollar question.
Yeah, again, shielding is one way of trying to get us to sort of live around this virus, because it's going to be with us for a while. I don't think we can pin our hopes on a vaccine this year or next year. It might happen, but I think that would be against expectations if we're being honest. So we have to learn to try and adapt our lives around that. And so shielding came at a time where we had no population record of accepting a shutdown. As it was, people to begin with accepted it really, really well, and largely continue to do so with some notable exceptions. So I think now we know, so we had to do that to get a rapid effect very, very quickly, so that we could minimize the amount of circulating infection in the population. If we get so we'll see what we talk about, the R rate is the transmission rate in the population. So if every one person with coronavirus affects, we say it could affect up to 3 other people, we need that to be below 1, and then the number of infections will drop down. We're in that phase at the moment where the number of infections is lessening, but it needs to reach a critical point at which time there's relatively little circulating virus in the population, and then it is safer to relax shielding. It's never going to be 100% safe, but if you're thinking about when you've been asked to shield, it's to stay away from, at the time, a high burden of the virus in the population. Now, in another few weeks, the burden of virus in the population should be much, much lower. So therefore, actually, enhanced social distancing might be all that's required for transplant recipients or people with cirrhosis and decompensated liver disease, because the amount of people that they might come into contact with who will have the virus will be far, far less. So I think, yes, there is a way out of shielding without a vaccine, but I think, is there a way back to normality of, going to large sporting venues? The answer is no. Concerts, no. So those things are going to be restricted, I think, for not just for people who are shielded, but for large, for all of us, for still some time to come, I think. You look at the Premier League are talking about going back now, but empty stadia. Rugby's talking about going back, but having less contact. How you do that in rugby, I have no idea. But the point is that I think the idea of going back to normal and what we used to do before this hit for a good while yet is not going to be reality, I don't think. But the shielding aspect of being stuck in your house, I can see a way out of that and still having minimal risk. And that might involve wearing a face mask when you go out in public. Being extremely fastidious with hand washing whenever you touch an external surface, for example. So if you've been out to collect some goods, when you come back, make sure that your hands are extremely thoroughly washed so there's no cross-contamination, for example. So yes, I do see a way out of shielding. Once the pool of coronavirus infections in the population is below a critical level. I'm not an epidemiologist, I can't tell you what level that is at, and I don't think we're at it yet, but I think we're getting towards it.
Good, thank you. And you might only be able to comment anecdotally, but do you know the percentage death rate for post-transplant patients from COVID-19?
Yeah. So the best evidence for this comes from the COVID Hep Consortium, which is a group in the States and Europe, and we've contributed a significant number of people with known liver disease or post-transplant to that category. Actually, we haven't contributed anybody post-transplant because we haven't had anybody in my area who's actually had a transplant and yet been known to be positive. Now, that cohort, they reported nearly 100 people with who've had a transplant, and that did report a 20% mortality rate, which sounds absolutely terrifying, but it's nowhere near that bad. Okay, the reason why it's nowhere near that bad is that these cohorts, where they're identified, it relies on interested people when they identify a case and know about this consortium collecting this data, putting data forward. So, and it tends to nearly always be in hospitalized people. So it's people who've got sick enough to need to go to hospital in the first place. And most people who have COVID will never need to go to hospital. So really, there's a huge ascertainment bias in the way these studies are put together. So they only pick the worst of the worst, if you like. What we don't understand is what's the total, unless we had data which showed how many transplant recipients are there in the country, how many of them have been admitted and had a positive COVID swab, how many of them had COVID symptoms. That's the only way to tell you what the true mortality rate would be, because we record mortality, but at the moment we don't know what the denominator is, which is the number of people who've had a transplant that have actually had coronavirus symptoms. And we may never know that, but without knowing that, anything is a massive overestimate. And if you look at UK deaths, it seems to suggest that 1 in 10 of people who get coronavirus dies. That is not true. It's probably going to be less than 1%, but it's because we're only testing people when they come into hospital by and large. We tested some people in the community, but if you're only testing the sickest people, you overestimate what the mortality is. So I'm pretty confident it's nowhere near 20%. Where we have to think about things though is what other risk factors are there. So we do understand that having diabetes, having a body mass index over 30, and being older, particularly over the age of 70, are risk factors for poor outcomes with COVID. And those are often the same with other influenzas as well, will often have a higher mortality with those sort of comorbidities. So I think we will see better intelligence telling us how we can better subdivide the risk, if you like. How can we better filter out what are the critically important risk factors for a worsened outcome? There's still no categorical evidence that having a transplant, if you're well, definitely increases your risk of death. We don't know that as of yet.
No, and from our group, we know of 2 PSC patients that are post-transplant that have had COVID. One of them had had the transplant less than a few months ago. Both of these patients had it very mildly. I know that's only 2 people, but it's still good to know that they've had it mildly, and we don't know of any others.
We've advised shielding because we don't know, and because particularly in the early post-transplant period, that's where you're putting at greatest risk of opportunistic infections. But people who are very well and are very fit and active, with no ongoing health conditions, who have had a transplant several years ago on low-level immunosuppressants, the risk is probably not that high. So if you read these reports, it sounds terrifying. The true mortality will be nowhere near those figures. Or if those figures are where they are high, there's often other reasons for a poor outcome. I didn't mention ethnicity, but that sometimes plays a part as well. So I think there will be other factors at play in identifying that 20% of people in that one reported study. And I know there's been a bit of noise about it in the media, but I think it's nowhere near that figure.
Good, thank you.
I've just got a question come in as well, which is sort of a similar question. Well, opposite question really, because we've heard a little bit about people who are on immunosuppressants and actually doing better if they get coronavirus because the effect it has on the immune system. So could you tell us anything about if there's any sort of evidence around that?
There's nothing as of yet that there is, but what we do understand about coronavirus is that the people who get really, really sick with it, particularly those who get the very bad lung injury, it's immune-mediated condition. So it's not necessarily the virus itself, it's your body's response to the virus itself that really causes a lot of that damage. And so, there's an attractive theory there that suppressing certain aspects of the immune system might prevent your immune system from overreacting to the virus or reacting in such a way that causes harm to your body. The true answer is we don't know if that is the case as of yet. And I think it'll take a long time to accrue that evidence because most people who have coronavirus are not transplant recipients. Most people who have coronavirus are not on immunosuppressants. So it'll take time to collect that data and to filter out what other risk factors there were. Were people very old? Did they have existing cancer, for example? Did they have morbid obesity as a risk factor? Once you've excluded all those things and controlled for those factors, only then will you be able to say, and you require, thousands, if not tens of thousands of people who've had a transplant to be able to sort of identify what the true risks are. So we don't really know. We do know that in the MERS outbreak in the Far East, in the Middle East rather, that they use mycophenolate, which is an immunosuppressant, as a treatment for some people. And there's one trial suggesting that might have led to better outcomes, but it wasn't a particularly big study. So it's interesting from a mechanism point of view that actually immunosuppression may not necessarily make it any more worse, any more severe rather, but we don't know for certain.
Thank you. I'm afraid our time is up. So thank you very much, Dr. Yeoman, for all your time and insights. It's been really, really fascinating. We've got loads more questions to ask here, actually, and we've not managed to get through all of them. We'd love you to come back again and answer some more. Would that be okay with you?
Yeah, no, just tell us the date and we'll make it happen.
Fantastic, thank you. And thank you everybody else for joining us today. This was really amazing and superb to be able to have these questions and answers. So I'm going to leave the last word with you, Dr. Yeoman. What is your takeaway message for people living with PSC during this time?
I think we understand your anxiety about the cessation of services. There's been a huge effort to try and mitigate that wherever possible, and hopefully some of those efforts will translate into real benefits for your care in the longer term. The single most important message is if you need healthcare, we are there and we want you to come. hospitals can be a safe environment for you to come to. We're doing everything we can to mitigate the risk and minimize the risk of exposure in our hospital settings. And if you're ill enough to need to come into hospital with cholangitis or any other complication of your PSC, we want to see you. We're there for you.